I think we're good to start.
Great. Okay. So welcome, everyone. It's really a pleasure to be here with you on this Thursday afternoon. My name's Liz Mugga. I am the Assistant Dean Wellness for the Faculty of Medicine. I'm also a family doctor working at the Briere Family Health Team. And I am delighted to be here to introduce Dr. Ed Spielg, who is our speaker today. This is part of a series of wellness webinars that we have been holding through our office, geared to faculty on issues that you bring forward to us that you're interested in. So thanks to you for supporting our webinar series. And I really hope this is, and well, I know that this will be a nourishing time that we will have with Dr. Ed Spielg, who is going to speak to us about moral injury and where we are at right now at this stage in the pandemic. And he promises to be a bit controversial. So that's always, I think, interesting too for all of us, coming onto a webinar. So please know that this session is being recorded. So you will get a link as a participant to the recording after the session is over, but just wanted to let you know the Q&A that we'll have at the end will not be recorded. So we'll keep that as a time if there are, personal stories or things you wanted to share that will not be part of the recording, and anything that you put in the chat or into the Q&A is not part of the recording as well. So which are the buttons down there at the bottom. I'll get into that in a second, but just wanted to let you know about the recording piece because you would have noted that as you entered. So before we go any further, I wanted to ground us in our Indigenous affirmation, and really, of course, we just had National Indigenous Peoples Day here in Canada, and so our minds are probably attuned a little more to the issues, and important that we start with that as we begin this session. So we pay respect to the Algonquin people who are the traditional guardians of this land. This is unceded Anishinaabe Algonquin territory that we're on, and we acknowledge their longstanding relationship with this territory. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. And we acknowledge the traditional knowledge keepers, both young and old, and honor their courageous leaders, past, present, and future, and recognize the important role that Indigenous knowledge has played in terms of the healing that we are all a part of as faculty members here in the university. So I mentioned, I think the slide just before Chantal that you just went over, which was just again to let you know that this was recorded. Thanks. And then the next slide following that. So this is our privacy obligations. Just make sure that we're being careful about any personal information we're sharing that has to do with learners or has to do with other colleagues or patients, of course. Next slide. Here is a bit more about patient privacy and PHIPAA and the regulations that we follow. The next slide, and some copyright information. So the session today, we have a 2-hour block. Dr. Spielg has told me he thinks he'll talk for about 45 to 50 minutes, and then we'll have time for a good Q&A at the end. As I said, if you look down on the bottom of the screen, if you hover over the bottom, you'll see there's a chat box. You're welcome to use that at any point during the presentation, and we'll make sure that we take a look at that. And he won't necessarily be able to see what's in the chat, but if there's a burning issue, we'll kind of grab him during or ask him to talk to that during his talk. Otherwise, we'll bring it to him at the end. And then there's a Q&A where if you put your question in, you can people can upvote that question, and then we can ask those to Dr. Spielg at the end. I wanted to let you know, I think, I'm not sure if Dr. Natalie Fleming is on yet, but she has kindly agreed to take over for me. I am delighted to be here for the front end of this session. I will have to step off. There's Natalie, perfect. So I will have to step off partway through. I have to catch a flight, and as some of you may know, the lineups are terrible now, and I'm on the last flight, but it does mean I will have to leave, unfortunately. But Natalie has agreed to take over and will be moderating the Q&A portion at the end. So I think without further ado, that's all the housekeeping, more than enough. So Dr. Spielg, I'm going to hand it over to you. I'm just so delighted you have come to join us. You are a real leader in terms of wellness research in our university. We're lucky to have you here as a part of the Faculty of Medicine on the leading edge of what we know about physician and healthcare well-being. So thank you for sharing this afternoon with us, and over to you.
Great, thank you, Liz. I'll just share my screen. So hopefully you've got that now.
Yes, we can see it.
Perfect, perfect. So thank you, first of all, for inviting me to talk today. I've given quite a few presentations over the last few years, talked a lot about burnout and physician wellness, but today I've chosen for my title, Moral Injury and Moral Residue in Health Professionals Following the Pandemic, whenever that may be, shifting the focus from wellness and burnout towards dealing with moral distress. See if that lets me. I have, the only disclosure I have is I've had some research funding from the Centre of Excellence on PTSD, funded by Veteran Affairs Canada. And my learning objectives are as described here, although I think they're not going to be quite as, I'm not going to divide up my talk into 3 clear sections, so there will be a little bit of sort of mixing up in different parts of my talk, and I apologize for that. So, a slide I've used many times in presentations. It was a slide which came from an article that Tate Shanafelt published, in the first 3 months of the pandemic, when we knew that it was clearly going to be a problem in terms of healthcare workers were going to be struggling with the being overwhelmed with everything that was going on. And they ran a series of focus groups, and they came up with some very nice, simple themes. And I think looking at this pictorial here, I'm not sure that there's much changed over the last 2.5 years over the course of the pandemic. I think people still feel, if they're asking about their organizations, they want to feel that someone's hearing them or listening to them and hearing them, that there's somebody looking out for them and is protecting them. Somebody's trying to prepare them for what's going to come. They're being should be supported, and that somebody actually cares for them. And I'll kind of let that sit with you in your mind and reflect on that as we go through the presentation today. And perhaps, we can come back to some of these thoughts later in the Q&A. So if you want to go looking for data on the impact on mental health of health professionals during the COVID-19, you are not going to be disappointed. In fact, the hardest thing is trying to assimilate all the data, because there's so much out there. It's incredible how we've got so many publications in such a short period of time, but a condition that nobody knew about 2.5 years ago, both in every aspect of treatment and now especially in the impacts it's having on the healthcare workforce. But this is stuff that I'm sure you've seen before. It's the same themes. We're seeing different percentages and different studies and different cohorts at different waves. But the bottom line is it has it's affecting every aspect of healthcare professionals' mental health, and not surprising because it's doing the same for the general public. And we've got many studies which have shown that as well. But I want to just take a step back, because I said in my title I was going to sort of try and shift the narrative away from burnout and wellness and try and encourage you to think about some of this more in the context of moral distress and moral injury. And I'm hoping that what I might be able to achieve by my presentation today is to help you get a bit of a different language and a different way of trying to frame maybe some of the feelings and experiences that you've had in the last couple of years during the pandemic, and hoping that if we can begin to focus more on maybe some more specifics of what some of the problems are, we might stand a better chance of being able to try and tackle some of the problems. So this is a graph. I had one that was, I think, went to 2016 before. I found this one up to 2020, which really just shows the number of articles that are being published every year on the subjects of burnout and wellness. You cannot keep up with it. 1,200 articles in 2020 alone on burnout. And I suspect in 2021, 2022, we're up to 3,000 articles a year, maybe more, that have that in the title alone. So it's very hard to keep up with the data. Everybody who writes an article on burnout will quote Christine Maslach 1982 definition. As stated here, I'm sure you know this, so I'll not read it out, but it's very specifically doesn't say anything here about this is a condition which only affects healthcare professionals. It was never designed as a tool to study specifically healthcare professionals, and yet it's probably been studied in healthcare professionals more than any other group in the last 30 or 40 years. So one of the problems with burnout as a concept, as a construct, is when you actually go looking for clarity as to, is there any consensus on what it means, what the criteria should be for diagnosing it, given that there even is now an ICD-10 criteria diagnosis of burnout. There are at least, and this was in 2020, at least 140 definitions of burnout. And different individuals, different groups frequently will assign burnout their own definition and their own significance. I hear frequently people talking about being burnt out, but then I turn on the television, listen to the radio, open the internet, and I just hear that everybody's burnt out. And clearly everybody's not going through all of the same feelings and having the same emotions. And clearly everybody says, I feel burnt out in the world, because probably about 2/3 of the population in the world at the moment are burnt out, are necessarily burnt out for the same reasons. When you actually look at the medical literature and people have tried to study burnout, the ranges are from 0 to 85%. I've seen many studies during COVID where people are reporting burnout rates of 20% in healthcare workers. And I'm thinking, how can that be? Because burnout, healthcare workers had rates of burnout of 40, 50%, 60% and higher before the pandemic. So how are we seeing burnout rates of 20 or 25% during COVID? And one of the problems is there's no real agreement as to which scales you should use, what cut points you should use, which definition you should use. And so we're not comparing like with like. And so this inconsistency across reporting of MBI scales is causing difficulty for many of us who are trying to study this area, because we can't really clearly gauge differences across time, compare between studies, compare within specialties, and it creates challenges to understand the relationship between burnout and other mental health constructs, such as depression, suicidality, and suicide. Probably over the last 6 years, which is the time that 7 years, time that I've been in Canada, we started to move away from talking about burnout, talking about wellness. And I'm here as a guest and as a member of the Faculty Wellness Program Advisory Committee, and I'm quite aware that wellness is part of the whole mantra of what we're trying to improve through our various committees. But unfortunately, when it comes to wellness, maybe not 140, but there's at least 100 different definitions. A whole array of suggested instruments, people claiming that, wellness is not as good as it was. How do you know? Because there's a scale which I measured which said so. But we're not comparing the same thing, not comparing like with like. And the trouble is, wellness and burnout are not opposites. They are separate and distinct entities. And the absence of one does not imply the presence of the other, or vice versa. And the other thing about wellness is, when you actually look at wellness frameworks, they often fail to explicitly acknowledge adversity. And this is a key component, I think, that's driving some of the problems which we face in healthcare and we have faced over the last couple of years. So wellness is often or usually tied to a sense of emotional well-being, happiness, positive sense of meaning at work, which can lead to the belief that wellness is therefore can only exist in the absence of adversity. But on the other hand, the practice of medicine, adversity is an inherent part of healthcare education and clinical practice. And we know how difficult medicine is as a field to navigate. And we know that it's inevitable to have negative emotional responses and that there will be tensions with patients, families, colleagues, hospitals, regulatory authorities, etc., etc. And these have been described as micro stresses that accumulate during the day in daily clinical care. And it's been suggested that, these in themselves are the kinds of adversities that we're faced with. They're not something that we can eliminate because they're just part of the practice of medicine. But nonetheless, they create this environment which causes some adversity. And those who are less experienced may feel more micro stresses and may have more negative emotions as a result. So I don't know if you've read the National Academy of Science, Engineering and Medicine report that was published in 2019. And it's frequently quoted as the sort of the go-to document if you want to get a good up-to-date view, well, 2019, fairly up-to-date, about what is the state of play with burnout and how we should fix it within the healthcare system. It's 335 pages long and it's a good read, and there's lots and lots and lots of good information in it. But it's tempting to skip through the preface. And I would encourage you just to be careful about that, because on the third page of the preface, which was written by the co-chairs of the committee who wrote the report, they make this comment. They say that the evidence for system interventions that significantly address clinician burnout is limited. And in light of the limited evidence base, the study committee was not able to provide specific recommendations for system interventions. So they've got lots of theoretical models about job resources and demands. They've got lots of stuff to say that personal individual factors are probably much, much, much less significant. But when it comes to despite all the focus on the need to address system level interventions, unfortunately, they couldn't actually list any that had any strong evidence base. And we know from many studies that have been carried out, when we try and shift the burnout needle, studies are moving it by only tiny amounts, and they're not repeatedly moving it. So it's not as if we're saying, well, it's moving in a little bit in the right direction and we're just going to keep going in that direction. We're not seeing the interventions at system level really making that much difference at the moment. And this led to an article that was in JAMA in 2020, which this was written by this group, who said that in the wake of more than a decade of assessments and interventions focused on burnout, none of which is proven to systematically improve conditions, it's time to consider reframing the concept of clinician distress. And that's really what I'm going to talk about today, because I think, I'm a subscriber of this belief that I think we do need to reframe this concept of clinician distress. I think we perhaps need to get away from this dichotomous position that everything is about individual and system level interventions. I think it's an oversimplistic approach to trying to oversimplify what is a very, very complex problem. And why does it matter if we use precise terms? Why not just talk about wellness? Why not just talk about wellness interventions, burnout interventions? Well, if we just want to fix burnout, then yes, let's talk about burnout interventions. But we know from the data that that's actually an incredibly difficult thing to do. The studies are not shifting that, as I said. So it matters. It matters because we want to ensure that those who are experiencing what we're trying to study and talk about actually have a language that accurately reflects their experience and that they feel understood. And promoting consistent terminology that we're all referring to the same condition and symptoms. And establishing an accurate diagnosis, which is the requisite first step in developing an effective treatment plan. That's what we're told in day one of medical school. I've surveyed groups and medical students and residents and other groups, and I've said, how many of you feel burnout today? And a lot of people put their hands up. And I'll say, how many of you felt burnt out last week? And a different group of people will put their hands up. And clearly, they're not describing burnout. They're describing maybe stress, they're maybe describing anxiety, they're maybe describing distress, they're maybe describing any number of emotional feelings. But it's unlikely that you're burnt out this week, but you're not burnt out last week, or you were burnt out last week, but you're not feeling burnt out this week. And this is the problem when we're not using consistent terminology across the piece. So I mentioned about these sort of micro stressors and talked about adversity. And I want to just elaborate a bit on that. Adversity is something that most of us don't really seek in medicine. We don't tend to go into the practice of medicine because we want to face moral adversity. However, there is absolutely no way we can avoid it. It is just so ensconced in everything we do that it's there. It arises whenever there's any internal, external circumstances or actions which produce some level of morally objectionable, troublesome, or unfortunate circumstances, which potentially might imperil our integrity or well-being, either individually or collectively. And that these responses may cause us to feel anxious, uneasy, uncertain, conflicted, and may lead to us having symptoms which are described, as I will talk about, moral distress and moral injury. So although we can't seek to avoid moral adversity, although we can't avoid it, I should say, we can choose how we react and respond when we're faced with it. And perhaps we also can expect our organizations to take some responsibility to the way that maybe we are exposed as people who work within this organization, the way that we're exposed to these moral adversities, and the way that the supports that we get to help us deal with these increasingly more challenging moral adversities that we have faced during the COVID pandemic. So what is moral distress? Well, I think the definitions are more consistent. There's variations of them, but this is a definition, a psychological response to an experience of moral conflict or moral constraint. And it's more likely to occur during public health emergencies or other situations where there are extreme resource limitations affecting patient care and the safety of healthcare workers. I never put a citation, that came from CMA. It arises when one's integrity is threatened as a result of some conflicting or unmet fundamental professional values that create this dissonance between what you believe you should do and what you're actually doing. So, I know we talk about perfectionism in healthcare and we try and discourage people from focusing too much on perfectionism and saying, don't worry about it. You don't have to focus on that. It's not the case that, there are standards of care, but often, we want to practice higher than the minimum standard of care that is considered acceptable. But oftentimes trying to practice at the level of care that we want leads to this gap between what we want and what we feel we can manage. And that is when we feel that our integrity, our professional and personal values can be threatened. And it occurs when a clinician feels unable to take what they believe to be the ethically appropriate right course of action. And when you break it down to that level of language, avoiding wrongdoing or harm because of institutional barriers or constraints, that's usually, if I'm talking to groups of people in person, I begin to see some heads nodding, because that's when people start to think, okay, that's a bit like what I maybe have felt myself in my clinical practice. Maybe I do feel a little bit where I have difficulty trying to do what I believe is the right course of action. And it's not because I've got a big ego, it's because it's just something that's been deeply ingrained into me that this is what I should be doing as a physician in whatever specialty, doing whatever procedure or intervention or treatment that I'm trained to do. So elements that bring up that involve moral distress include complicity in wrongdoing. So if you believe you're doing the wrong thing, but you have little power to change the situation. There's a term called moral agency, which in simple terms means just lack of voice. When you believe that you have the insights and knowledge relevant to the situation, you are an expert, but people aren't listening to you or they're not taking you seriously. that there may be wrongdoing associated with professional values. So somebody might set professional standards of care or service delivery that are just not possible to carry out because of rationing, limitations, HR problems, resources aren't available yet. And then another significant component, and this is where we get into the post-pandemic, is the problem with repeated episodes of moral distress, which leave what is termed moral residue, which is a heightening an individual's level of moral distress in subsequent experiences. And I think one of the biggest barriers that we're going to face as in healthcare, moving on in the recovery phase, is if we don't address the moral residue, then we're going to lead to more moral problems when we reach with more moral distress, when we encounter further problems, as we inevitably will in our professional practices. And the consequences for moral distress in healthcare are very well described. Lots of emotional challenges, words here that sound a bit like burnout, like, you know, we're going to get exhaustion, emotional detachment. So absolutely, moral distress is a recognized cause of burnout in healthcare. Is it the biggest cause of burnout in healthcare? I don't know, but I think it's a significant cause of burnout in healthcare. And the pandemic has really shone a light onto that. And that's why, you know, me and others are talking about this at the moment. It certainly affects quality of care. It certainly affects satisfaction. It certainly affects physicians' ability to advocate for patients. And people quit. We're seeing it in nursing and we're seeing it in medicine. And this is a real problem, because all that's doing is adding to the pressure and the stresses of everybody else who's left trying to hold up a creaking system. And Hamrick and Epstein talked about this moral residue crescendo. So as each episode of moral distress passes, maybe we're getting over this wave and we're getting into recovery. Is it resolved? But maybe sufficient processing. But if not, it's going to leave a little bit of moral residue. And then when there's subsequent incidents of moral dilemma or moral distress, then these become less tolerable and we kind of recover a little bit. And then it happens again. So as this residue accumulates, we move closer towards this moral injury with subsequent dilemmas or distress. So we may feel that we're in a recovery phase and we may feel good about things, but if we don't really talk about the moral dimension for what we faced and we don't try and address the moral residue that's built up in all of us over the last 2.5 years, then we are a heightened level of sensitization for further moral distress, which may not be due to such severe problems, but for us as individuals may actually have more significant consequences. And the more significant consequences that we develop moral injury. And, you know, before moral injury, it was more talking about the residue of consequences which clinicians experienced in their roles. But since then, we've kind of thinking about more like it's the way it's considered in the military. This exposure to circumstances that violate one's moral values and beliefs in a way that erodes integrity, moral capability, perception of basic goodness, and creates distress on a psychological, behavioral, social, or spiritual level. That's a military definition, but it's equally applicable to what healthcare professionals have experienced during the pandemic. And it's a profound level of psychological distress, and distress being the operative word here. And it results from actions or lack of them which violate one's moral or ethical code. So it's not what violates somebody else's moral or ethical code. This is personal. This is something about your own personal values, morals, ethics. And when they're transgressed or you witness transgression of those, then, or do something which transgresses those values, then it's very hard for you to deal with that. That's just a fact of life. And so witnessing or participating in moral wrongdoing or a term which is frequently used, and I'll talk a little bit about it, is this notion of feeling betrayed by leaders. The other phrase that comes up a lot is that when one feels that an individual or institution has a duty of care and has failed to do so. So we hear fail to do so. We hear a lot about duty of care in our professional practice, we have a duty of care to our patients. But increasingly, we're starting to hear this conversation about, well, do the people who run the places that we work not have a duty of care to provide us with this type of environment that's going to protect us and not cause us moral injury? And certainly in the military over the last 20 years, there's been much more light shone on the responsibility of those who are overseeing the military processes to acknowledge that they do have, to some extent, a duty of care, duty to provide care for those that they are putting in situations where they're at high risk of developing moral injury, as we increasingly are in that environment as healthcare professionals. And the outcomes of moral injury are the same and more of moral distress. More feelings of guilt and shame, elevated symptoms of anxiety, but depression, and then PTSD and suicidality. So there was a scoping review published just this year by this group, Riedel et al., where they really delved into, in all the literature that's been published in the last 2.5 years on COVID-19, what are the identified moral stressors which healthcare professionals have faced? Well, this is a list of all the patient-related moral stressors. I'm not going to read all these out, but hopefully you can scan through them. And I would be very surprised if people watching this just now don't feel that they can recognize quite a few of these moral stressors in their jobs that they've experienced in the past few years. But not only patient-related, there's been stressors related to interpersonal relationships, be that doctors, nurses, nurses, and then healthcare professional patients, for many reasons to do with treatment planning, disregarding others' opinions and treatment decisions. Nurses will have a view, physicians will have a view, patients will have a view, cultural differences, communications, conflicts, teams changing, people ending up with different levels of competence in teams because they're brought in, or witnessing people acting, unsafely or not following safety guidelines. And then they divided, the third group they talked about was the organizational constraints, which have created moral stressors in all the studies. And there's conflict between resources and distribution, PPE, working conditions. Again, this comment, betrayal by hospital leadership and by others, lacking management support, feeling dehumanized, and being treated as a replaceable resource. Definitely, there's been studies, I've written about some of them myself, where that's what physicians are saying, that they genuinely feel dehumanized by the system in which they're being asked to work in. Lack of empathy, lack of support, conflicts between ethical principles and ethical decision-making, etc., etc. And then it brings in the whole family dimension of trying to balance what you feel you want to do for your professional practice and what you have to expose yourself to at work and your personal and family obligations. Symptoms of moral injury during COVID-19 seem to be triggered by stressors at individual level, as discussed here, causing betrayal, guilt, shame, these kind of symptoms, which we've alluded to. They also can be triggered by stressors at team organizational level, slightly different types of symptoms. This is more anger with blame and frustration, and anger and cynicism, and maybe you felt this yourself, or maybe you've witnessed this in colleagues. And then at an organizational level, these kind of triggers of these stressors lead to things like lack or loss of leadership, or trust in leadership. And worryingly is when you get diminished commitment to the organization, which affects engagement, productivity, quality, and people leave. Other vulnerability indicators for moral distress and moral injury that we can take from all the studies that are out there? Well, individual factors seem to be people who don't have, interestingly, a religious affiliation or low identification with religion seem to be at greater vulnerability, so the studies say. People who have low levels of self-compassion, higher self-criticism, people who are younger, less work experience, females, lower education background, seem to be more vulnerable to experiencing moral distress and moral injury once they are exposed to moral stressors. And then there's these organizational factors. Professional group nurses tend to score higher than other people, other work groups, people that are exposed to violence, unsafe working practices. Not surprisingly, COVID-19 patients, stress, workplace environment, poor communication, and lack of knowledge and experience. How prevalent is moral distress? Well, in this study in the United States, where they surveyed during the height of the New York pandemic, they found that about, between 50 and 80, 85, 90% of healthcare workers endorsed moral distress. And the key is, what happened after that? And the data is not really there to show what level of moral residue we're seeing in that group, but it's probably not gone back to zero. An Israeli study did the same kind of thing, asking its healthcare staff, looking at moral injury and other outcomes during the pandemic. A third reported transgressions of their own moral values. Almost half witnessed things that they felt were morally wrong. Half reported experiencing at least one transgression by somebody else. More than half reported betrayal by hospital leadership, and nearly 2/3 reported betrayal by others. And in moral injury, it's less, as you'd expect, because one has to have more severe moral distress to have moral injury. But maybe based on US data, which is maybe more comparable to ours, about a third of healthcare professionals seem to be having more clinically significant moral injury during the pandemic. And when you think about it, we were worrying about a third of physicians having burnout before the pandemic, but now we're talking about, it's not just burnout, they're not just tired, they're not just exhausted, they're actually got something which is actually a lot more worrying and potentially a lot more harmful to them and more destructive. So if I just take a step back to thinking about us and ourselves and our practice and what we've experienced for the past year, I think we can say that all clinicians know that they will encounter moral dilemmas in medicine. You're told that. If you don't know that, you'll have realized that by the end of your first or second year in med school. And, at the moment, I think everybody would not argue that these times are deeply challenging. We have deeply difficult decisions to make. And the problem is that often more than one answer is morally defensible. And when it comes down to it, you're caught between a rock and a hard place. Resolving dilemmas is something that we're trained to do, and everybody talks about the need to be educated about how to initiate discussions, consult ethics teams, because although it's expected that we're going to encounter these situations, they are very, very difficult. And we know that when clinicians are physically and emotionally exhausted with navigating what is a difficult and challenging healthcare system, their efforts providing good care will reach eventually, for many of us, a state of learned helplessness, and we just sometimes feel like giving up. We can feel less effective. We feel that we're not accomplishing what we should be doing with the tools and the treatment modalities that we have. We sometimes feel that the challenges to try and fix the system are futile. Therefore, the only way we can deal with it is to protect ourselves by emotionally distancing ourselves. And that's when we depersonalize. It's the only way sometimes that we feel we can tolerate the inescapable exposure to the suffering that we're witnessing our patients having at the moment. And so it is a coping strategy to withstand what is described as intolerable, inescapable situations. But it's not a good coping strategy, it's a maladaptive coping strategy. And when you get to that point, that's when you're starting to really show signs of moral injury, the end stage of distress, leading to burnout. And so this is what Linzer and Poplow proposed as a model for this. And I quite like this model because it doesn't use the terms individual level and system level. It talks about the practice of medicine will inevitably bring about moral dilemmas, which for some will cause moral distress. Not everybody gets moral distress when they're faced with moral dilemmas, but we know that, from the studies, the greater the dilemma and the greater the challenge and the less options that people feel are available to them, the more distressed they're likely to feel. And in more severe cases, that's going to lead to moral injury. Feed into that the work conditions. This is the system level bit, the time pressures, the chaos, the work control, the organizational culture, focusing on quality, values, alignment, communication, trust, cohesion. This is the system level bit. But you could say that system level applies to every single organization in the entire world. There's nothing different about the work conditions that create burnout in healthcare than create burnout in any other occupation in any other organization. What's different about healthcare is we have the practice of medicine that feeds into these, that's feeding in moral dilemmas every single minute of every single day that we work and deal and support and care for our patients. And so the intersection between the work conditions and the practice of medicine is what's causing some of the problem, a big part of the problem. And so if somebody goes in and tries to fix the problem by addressing the work conditions without really understanding the practice and the culture of medicine, you're unlikely to significantly impact burnout. And when you get to the point of moral injury, you're starting to feel burnout. But you want to try and address burnout, maybe we should start to go a stage back and look at the moral injury and the moral distress. So have you experienced moral distress yourself during the pandemic? Have you felt unable to do the right thing? Do you feel your values are being compromised or undermined? Do you feel like you're unable to meet your professional obligations or be the kind of professional you should be? Are you faced with new or extremely complex issues that are ethically challenging and unsure how to move forward? I'd love to be able to say, click a button, say, yes, if you are, go here, we've got the answers for you, but we don't. Not yet. We might in due course. We're seeing moral constraint distress in healthcare professionals, physicians particularly. We've got reduced provision of health services, people feeling unjustifiably responsible for patient outcomes when they haven't caused the problem. They can't perform in-person examinations. They can't perform surgeries and other outpatient procedures, and therefore they're constrained from this, and therefore harm is arising, which they feel responsible for. There may be examples with moral constraint regarding triage and allocation of resources, and making independent, ethically supportable decisions, which often will violate one's own values. Even things like teaching can cause moral distress. I've heard physicians telling me that they feel constrained to be complicit in potential shortcomings in learners' education. They just don't have the opportunity. The students are not allowed into the wards. They've had to, initially they weren't allowed to be part of the process. Their learning opportunities were taken away from them. And so that, in some respects, and we were spending more time doing other things, service commitments, covering for staff who weren't present because they were off with COVID. We felt, moral distress because we knew that the students needed the training and needed to learn, and we couldn't deliver that. And we knew that that was going to cause them distress as well. And one of our key roles as physicians is not just about caring for our patients, but also imparting that knowledge and learning to our learners and future physicians. We've been exposed to moral uncertainty distress, uncertain about the right thing to do, whether that's to do with, do we let people in to visit, do we not, that kind of thing. Moral dilemma distress, well, we're faced with lots of these issues, risks to personal safety versus risks to loved ones, balancing these acts, provision of healthcare services, obligation to provide high quality care, but at the same time, we have to follow infection control and public health practices, making decisions based on resources, scarce resources. That's another one. Managing conflict or moral conflict distress. You don't know which is the best action. And this is causing anger and frustration, risk to personal safety. So maintaining your own safety may lead to substandard care. A good example of that is when, and people are now used to it, but when code blue was called in the hospital, you don't run into the room, you put your PPE on first. Putting PPE on might take 2 minutes, and we all know that that could make a difference to the outcome. But on the other hand, you have to maintain your own safety. That was what we were told to do. And And another example of moral conflict is what we said to do with performing outpatient treatments. You know, you understand why you may be not able to do so, but you're really conflicted about this because others are not maybe understanding the reasons why you feel that the need outweighs the potential reasons why you're being told you shouldn't do what you're being told to do. And then moral tension, distress. This is an example of this would be to do with triage, allocation, resources, where you might feel unsafe or constrained to voice your concerns or express your views, because if you do, there's the risk of repercussion. So I've talked quite a lot so far about everything's bad. Moral distress is not good. Moral injury is very bad. And the numbers of moral stressors which physicians and other healthcare professionals have been exposed to during the pandemic has grown exponentially. We couldn't have imagined some of these moral stressors which we have now experienced. And many of them, even though we're getting less in the pandemic, are still there. And they could easily come back, as we're starting to see in other countries, other continents. I noticed in the news the other day, 30% rise in the UK in COVID cases in the last week due to different variants of Omicron. So this has not gone away. And anybody who thinks it has, and we're now in the purely recovery phase, may find that they're needing to be stopped in their tracks. Moral resilience is something I want to talk a little bit about because it's a construct which has been discussed over the last few years. It's not quite the same as resilience. It's not just talking about people being able to withstand the knocks. And I know that physicians don't like the term resilience. They see it as a dirty word, and they think that focusing on resilience implies that there's a weakness in them. But I want you just, if you've got that approach to resilience, and maybe some of you have, I want you just to put that to one side while we just think specifically about resilience in a moral context. The capacity to sustain or restore your integrity in response to moral adversity. And maybe that is a means to transform moral suffering in healthcare. And maybe it allows a way of buffering against moral injury and negative consequences. It's certainly in my mind, one of the more intriguing constructs that perhaps actually offers a different way, a different lens to look at this problem, and maybe offers a different way of trying to address or come about different solutions. So maybe that it looks at ways that we respond, how we can respond differently during a pandemic, and also thinking about how it interacts with the systemic factors that are creating a lot of these moral and ethical stresses. So as I said, it may be a way of mitigating moral adversity. It allows for exploration of factors, individual and organizational. So if that's a big way you want to think about this, then it should fit in with your model. But it also is being proposed to help clinicians practice in a manner that reflects their intentions, character, and integrity. So as I said, you're faced with the situation you're faced with, but at the end of the day, how you deal with that and how you grow from that and how you go home and how you treat other human beings, your loved ones, the people that are most important in your life, you know, to some extent, can we change that? And, you know, what's the role and responsibility of our organizations to help deal with that? So again, I'm not suggesting that moral resilience, the responsibility for this lies with individuals. This is very much a cultural issue and a systemic issue. It focuses on these constructs: self-regulation, moral agency, we've mentioned a bit about that, ability to make ethical decisions based on what's right and wrong and be held accountable, self-stewardship, looking after yourself, moral sensitivity. This is a big issue. It's been talked about quite a bit in intensive care, critical care, emergency departments, but maybe not in this term, but it's this interplay between personal values and values of other interdisciplinary clinicians. When we're kind of sitting around discussing, when whoever's making the decision, whether it's the attending MD or whatever, you know, what about how sensitive are we to the moral views and the integrity of others? And do we consider in our day-to-day practice how the decisions that we make perhaps might cause others moral distress. So we focus very much on our own moral distress, but how in tune are we with things that we do unintentionally, of course, which might actually contribute to other people's moral distress. And then there's moral judgment and moral action. Until 2021, we did not have a way of measuring moral resilience, but like everything else in this world, somebody will always come up with a tool that allows you to measure it. So this is the one and only tool at the moment. It measures responses to moral adversity. So do you feel powerless, overwhelmed, weighed down from facing ethical challenges? Do you, your personal integrity? So how consistent are you upholding your values in response to moral adversity? Your moral efficacy, how confident are you, or capable are you to address ethical challenges and advocate for yourself, your values in the face of ethical conflicts? And it measures your relational integrity, whether you recognize the important interplay between your personal values and the values of others that you work with. And it's proposed that cultivating moral resilience with systemic redesign of healthcare systems to dismantle the impediments to ethical practice may offer a direction that's promising to lead to some culture change. And it may mitigate against burnout. It may impact culture. It may create healthier work environments. It may distinguish between unique aspects, both moral and ethical, which contribute to burnout. It may create a foundation for tailored programs. It may make people feel that they're being heard and listened to because we're changing the culture of the organization, and that people feel and that there is more than just a feeling of a duty of care being offered, but there is care being offered by organizations to support. We wanted to study this construct of moral distress and moral resilience, so we carried out a survey of Canadian healthcare workers during the first wave of the COVID crisis back in 2020. We looked at comparing groups who were exposed to COVID and groups of healthcare staff who were not exposed to COVID, and we performed linear regression. We came up with a model which talked about, that suggested that moral resilience may buffer the effects of potentially morally distressing events causing moral distress and therefore poorer mental health. And if we could intervene at the level of trying to mitigate against the stressor causing the distress, we may prevent mental health problems. And when we compare the two groups, the no contact in the light blue and the COVID contact in the dark blue, when we measured moral distress, stress, anxiety, and depression in the top row there, we found that there were significant differences between the levels of all these constructs in the staff who were caring for COVID patients and the staff who had no contact. But the biggest difference was when we measured moral distress. And when we looked at exposure to potentially morally distressing events and moral distress, and we factored in scores of moral resilience, what we found was that individuals who had higher levels of moral resilience experienced lower levels of moral distress when they were exposed to the same potentially morally distressing event. So it seems to be having an impact. And, you know, we probably know this ourselves. We know, when we look at our colleagues, that some of us have greater levels of distress in certain situations than others. Now, we often think, well, maybe they just don't care as much as I do, but it's almost certainly not the case. I think everybody cares just as much. It's just some people are maybe better at being able to manage this moral stress that they're experiencing and causes less distress. So our findings are pretty much what I've said, that COVID-19 staff who cared for patients had significantly more moral distress, anxiety, depression, more self-reported mental disorders, higher exposure to potentially moral injurious events, and lower moral resilience were associated with worse moral distress. That moral resilience seemed to moderate the relationship between exposure to PMDEs and moral distress, with lower stress, anxiety, and depression. And so perhaps by intervening at that level before moral distress arises, we can help people deal with the moral stressors and the moral adversity that they have experienced. So what do we do? Let's talk about that for the last few minutes. And because unfortunately, we don't actually know the right thing to do. This was what people published in 2020, and they said much of the available guidance is led by blah, blah, blah. I think they hoped by 2022, we would actually have lots of evidence that would tell us what to do. Unfortunately, we don't. This is one of the very few systematic reviews that have looked at trying to reduce moral distress in clinicians. Most of the studies have looked in the intensive care, critical care setting, and most of them are really only studied nurses. And here's a review that was published last year, 12 studies, only 3 RCTs, 9 interventions just involved nurses. The kind of interventions are mainly of an educational nature. None of them really jump out and get you kind of excited. And not surprisingly, it says overall low methodological quality and high risk of bias. No single intervention may be considered efficacious in managing moral distress. So you might read from that, okay, well, maybe that means that moral distress isn't a problem because we can't affect it. And it's not the cause of burnout or moral injury in the group. But I think looking at the nature of the research, the problem is we actually just haven't done good enough studies, and we don't really yet know what is the best interventions to try and implement to manage moral distress. So we need interventions to mitigate the impacts of morally distressing events somehow or other, to reduce the frequency and intensity of exposure. And that's where organizations can have a role to play. And they can also have a role to play in cultivating the capacities of this moral resilience as a protective factor while systemic reforms are implemented. And then we have to think about what are the institutional structures which identify and respond to ethical concerns when they arise. Do we create spaces for dialogue and discussion, structured debriefings, peer-to-peer support? This is not something that should be the exception rather than the rule. This is something that should be embedded into everyday practice, and not just in the critical care setting, but across healthcare. And it should be led by not amateurs, but facilitators trained in the nuances of ethical practice. We're trying to find some answers locally. We've got a couple of scoping reviews in process, one which we'll hopefully report on after the summer, looking at interventions to reduce moral distress and moral injury and promote moral resilience in not just healthcare workers, but first responders and military personnel. You'd think, well, maybe someone's done this before, but they haven't. And another study being led by one of our own residents and med students in Ottawa U, looking at interventions to promote medical trainee help seeking for mental health concerns, a really important area, and looking at some of the barriers which perhaps exist to prevent this happening. We've also got an intervention study in TOH. Those who are working in TOH will, with the next few weeks, get an invitation to participate in an implementation of a feasibility of an intervention where we're going to measure many of the constructs we've talked about today. It's not going to solve the problem, but it's going to give us some information. It's going to help build an evidence base to try and work out how we can actually try and address some of these moral challenges individuals are facing. So what do we do in the meantime? What's the best guess? Well, I think the best guess is probably the following. I think individuals need to think about looking after themselves. I think they need to seek peer support when necessary and seek ethical support when necessary, and organizations need to provide that when it's needed. Experiences need to be shared, and there needs to remember that there is help if things get out of hand. Managers and leaders need to immediately recognize and address the experience and significance of this problem. And when they're holding meetings and huddles, they need to be thinking not just about cohesion and communication and decision making, but also allowing for shared experiences. And they need to be thinking about how do they strengthen relational integrity amongst teams, and thinking about working with an ethicist. I'm sure some of you during the last 2.5 years have directly worked with an ethicist, but I've spoken to many physicians that have had no direct contact with an ethicist. And of course, there are major shortages and everybody wants, so they have to prioritize what they do. But that's, given that we're talking about moral and ethical dilemmas here, maybe that's an area that organizations need to look at. And then managing moral distress from an organizational perspective, recognizing and validating this experience. Do you hear from your organizational leaders, we are in this together? Do you hear the phrase, we have your back? Clarify processes when ethical conflicts arise, be honest and transparent. You haven't created, the leaders, our organizational leaders didn't create the pandemic, but they have to be honest and provide clear guidance. And if we're told to go into urgent triage mode, what's the plan to mitigate against providers' moral distress? Because when you press that urgent triage button, there will be a sudden spike in moral distress. So how are we going to deal with that? Don't wait till it's happened, but we should have a plan that we press the button at the same time or 1 minute later. Providing clear advertising supports and resources to minimize their moral residue. That's going to be a critical factor as we move forward in the post-pandemic era. Providing opportunities to practice self-care, learning from what's happened, and then to educational establishments to intensify the content related to building ethical competence and moral resilience in our UG and PG curricula, and how we extend these skills into clinical practice. I'll come back to this slide as my last slide before I sign off, and to say that if we think about this model that Linz and Poplau proposed, they come up with an interesting way of reflecting on it. They suggest that yes, we do need some individual and team ways of trying to prevent moral dilemmas causing moral distress. That's done at the clinical team level on the unit. We need system level changes to look at the way that the work conditions and all the things on the bottom here are contributing to moral injury. That's what our professional organizations are fighting for every day with our governments, and we should commend them for doing so. But the system level changes also need to look at what is it that's driving the moral distress and what is it that's also contributing to the moral injury. And if we only focus on the work conditions and we don't address the other issue, then we're not going to be able to deal with one of the major drivers of burnout and all the problems that we're seeing caused here. So I'll leave you with my last quote, which is that the most important human endeavor is the striving for morality in our actions. Our inner balance and even our very existence depends on it, and only